Hello everyone. In this particular lecture, we'll be dealing about cardiology, and in cardiology, our topic of concern for today's lecture is WPW, that is Wolff-Parkinson-White. So there are two different conditions. First one is only WPW pattern, and another is WPW syndrome. So WPW pattern is nothing but there is the ECG evidence. Okay, if there is any ECG evidence of ventricular pre-excitation complexes in ECG, then that is WPW pattern. However, there is no evidence of arrhythmia. There is no reported symptom in the patient. In WPW syndrome, in addition to ECG changes, there will be evidence of arrhythmia and there will be reported symptoms. Regarding the main pathophysiology of WPW syndromes, it's the intermittent tachyarrhythmia, mainly because of accessory pathway, and this accessory pathway are termed as bundle of Kent. So bundle of Kent is that accessory pathway which bypasses AV node. So if this bundle of Kent bypasses AV node, then the impulse from SC node can easily propagate, or it can easily transmit into ventricles. So this bundle of Kent, they bypasses AV node, and the impulses easily pass from the SC node into the ventricles. So sometimes these WPW syndromes can be associated with the Ebstein anomaly, and this Ebstein anomaly is strongly associated with maternal lithium exposure. The lithium is one of the mood stabilizing agent used in bipolar disorders, and use of lithium in mother increases the risk of having Ebstein anomaly in fetus, and this Ebstein anomaly is associated with having Wolff-Parkinson-White syndromes. There are certain other arrhythmia which are strongly associated with WPW syndromes, including AV atrioventricular reciprocating tachycardia. 80% of the patient with WP syndromes, they will have AVRT. Around 30% will have atrial fibrillation, and a few people will have atrial flutter, and very rare population, very rare subsets of people will have the arrhythmia like multifocal atrial tachycardia, ventricular fibrillations like such. So ECG findings of WPW syndrome is one of the high yield area. So it's mainly because of this accessory pathway known as bundle of Kent. So because of these accessory pathways, the AV node has been bypassed. The normal function of AV node is it creates intrinsic delay in transmission of impulses from SA node through the AV node into the bundle branches, and finally into the Purkinje fibers. So because this AV node has been bypassed, the impulse can easily and in a faster manner, in a faster rate, can get transmitted from SA node into the ventricles, because of which the PR interval. So PR interval is nothing but the representation of intrinsic delay of AV node. So if the AV node is stronger, then the latency period, the PR interval will get longer. And if this AV node has been bypassed, or AV node has been weaker, then this PR interval gets shortened. So here, because of these what we say, the accessory pathways, the bundle of Kent, the PR interval gets shortened, and there is something called delta wave. So delta wave is the upslowing upstroke of the QRS complexes. So it represents there has been the impulse has been transmitting from these accessory pathways. So that represents the delta waves, and because of all these changes, there will be widening of QRS complexes. This delta waves, however, is not seen in all patients. So these are the characteristic ECG findings of WPW syndrome. However, if WPW syndrome is associated with other arrhythmia like AVRT, atrial fibrillation, atrial flutter, then the ECG changes of those arrhythmia can also be observed in the ECG. So regarding management of atrial fibrillation, there is the management can be categorized into two different ways. The first is for the acute episode management, and another is the long-term management. So let's first see about acute episode. In acute episode, we see the hemodynamical stability of the patient. If the patient is hemodynamically unstable, then we do straightforward electrical cardioversion. However, if the patient is hemodynamically stable, then we see the ECG. If the patient is having wide complex tachycardia, then we do rhythm controls maneuvers, like we can do cardioversions as such, or we can use the drugs like IV procainamide. But the catch here is we should avoid the AV nodal blocking agent, like we should avoid the drugs like adenosine beta blockers, non-dihydropyridine calcium channel blockers, including verapamil and diltiazem and digoxin, because they can precipitate fatal ventricular tachycardia, ventricular fibrillation in those patients. And also, we should avoid vagal maneuver for the same reason. The vagal maneuver also increases the activity of AV node, because the AV node is highly innervated by the vagus nerve, and whenever we do vagal maneuvers, then AV node gets blocked or AV nodes gets activated for the longer durations, and the patient can have fatal ventricular tachycardia or fatal ventricular fibrillations. Regarding another ECG changes, like if the patient is having regular narrow complex tachycardia and the patient is hemodynamically stable, then we can use vagal maneuvers or adenosine for that case only. And regarding long-term management of WPW syndrome, we do risk stratification based on clinical history, ECG findings, and electrophysiological parameters. And depending on these parameters, we stratify the patient as having high risk and the low risk. For high risk patient, only management that has been approved is catheter ablation of accessory pathway. However, if the patient has been categorized into low risk, then we see the symptom of the patient. If the patient is asymptomatic, then we do simple observation only. However, if the patient is symptomatic, then the first line itself is again cardiac catheter ablations of this accessory bundle of Kent. And for the second line management, we do long-term antiarrhythmics. Like we can, when we see the any structural heart disease of the patient. If there is any structural heart disease, then we can use the drugs like dofetilide and sotalol. And if there is no any structural heart disease, then we can use the drugs like flecainide and propafenone. These are the long-term use of antiarrhythmic drugs. However, these antiarrhythmic drugs itself are the second line drugs. The first line management for symptomatic and low risk cardiac WPW syndrome is cardiac catheter ablation of radiofrequency ablation of this accessory bundle of Kent. So with this, we conclude Wolff-Parkinson-White syndrome, one of the characteristically high yield point. And thank you for your time and attention.